Imagine ringing the bell at the cancer clinic. You know, you survived.
Mm.
Everyone is cheering. Your family is crying. The nurses are clapping.
Yeah, it's a huge moment.
It is. You made it to the life raft.
Well,
But what almost no one tells you in that celebratory moment is that the very treatments that saved your life might have completely dismantled your sex life.
right.
And the most shocking part, I mean, your doctor probably won't even bring it up.
No, they usually don't. That bell ringing ceremony, it marks the end of a physical crisis, but it often marks the beginning of a profound silent struggle.
Exactly.
Because when you're treading water in the open ocean, surviving a literal threat to your existence, you aren't worried about the thread count of the blankets on the rescue ship.
Right, you're just happy to be on the ship.
Exactly. You are in pure primal survival mode. But 6 months later, when you are back on dry land and expected to just resume your normal existence, the quality of that everyday life suddenly matters immensely.
It really does.
The landscape of your own body has changed, and navigating that new terrain requires a completely different set of tools.
Which is exactly what we are getting into today on this deep dive.
Yes, we have a lot to cover.
We really do. So if you are listening to this, whether you are a survivor yourself, a partner to one, or just a medical student or professional who wants to understand the real aftermath of a major medical trauma, we are unpacking the profoundly altered physical and emotional landscape of sexual health for breast cancer survivors.
And we're pulling all of this from an incredibly comprehensive guide called 100 Questions and Answers about breast cancer sensuality, sexuality, and intimacy.
Right, written by a trio of specialists, right? Dr. Michael L. Krychman, Susan Kellogg Spadt, and Sandra Finestone.
That's right. And the real value of this specific source is how it bridges the gap between the cold biological realities of oncology and the deeply personal lived experiences of intimacy.
It really balances the two.
It does. As an educational creator and medical expert, I really want us to look under the hood today at the specific mechanisms like how treatments actually rewire the body's nerve pathways and hormones.
The actual hardware changes.
Precisely. And then map out the actionable science-backed strategies used to rebuild that vital human connection.
So before we get into the heavy biology, we need to completely reframe how we view life after cancer. The source material leans heavily into this concept called survivorship medicine.
Yes, a very important shift in the field.
Reading through this, it struck me that it's a lot like the transition from the emergency room to a long-term physical therapy clinic.
That's a great way to put it.
Because, the ER doctor's only job is to stop the bleeding and keep your heart beating. They don't really care if you can run a marathon later.
No, they're just keeping you alive.
Right. But the physical therapist's entire job is to make sure your life is functional and mobile and, joyful again.
That is a perfect framework. Historically, oncology was entirely an ER mindset. Eradicate the disease at all costs. But survivorship medicine is a massive paradigm shift.
It really changes the goalposts.
It does. It rejects the idea that patients should just accept disease-imposed limitations as the price of survival. Instead of viewing you as a victim who should just be, grateful to be breathing, it views you as a thriver.
I love that term, thriver.
Me too.
Yeah.
The clinical goal becomes optimizing wellness, and sexual health is a foundational, non-negotiable pillar of that wellness.
And yet it is somehow the most neglected pillar. I mean, the statistics in this book are staggering.
They really are sobering.
The American Cancer Society estimates that 90% of breast cancer survivors experience some significant alteration in their sexuality.
90%.
Right. We were talking about plummeting desire, loss of physical arousal, the inability to reach orgasm, or the sudden onset of severe physical pain during intimacy. 90%.
Yeah.
It is virtually a universal experience. It's not an outlier.
And the disparity between how much patients care about this and how much doctors talk about it, that is where the real tragedy lies.
Oh, sure.
The text cites a national survey showing 81% of women believe sexual health is vital for their overall well-being. They actually rank it above career satisfaction and travel.
Wow, above career and travel.
Yeah. Yet, while 70% of these women are actively experiencing sexual difficulties post-treatment, only 18% ever have a conversation with their doctor about it.
Just 18%. I found myself wondering how that collusion of silence happens.
Yeah.
Because if I am in pain, I tell my doctor.
Right. A broken arm gets brought up immediately.
Exactly. But with intimacy, there is this immense shame on the patient's side. You feel this societal pressure that says, well, hey, you didn't die of cancer. You should just be grateful. Don't be greedy and ask for a sex life, too.
Yes, that guilt is a huge barrier.
And then on the provider's side, you have oncologists who are hyper-focused on protocols, CT scans, and tumor markers.
Well, and standard medical consultations are barely 15 minutes long. A doctor doesn't have the time and honestly often lacks the specialized sexology training to initiate a highly nuanced, emotionally charged conversation about libido.
Right. It's not something you can just breeze through in 2 minutes.
Exactly. So the implicit, unspoken message lingering in the exam room becomes, we saved your life. Please don't ask us to fix your marriage, too.
Wow. That's harsh, but probably very true.
It is. And it totally conflates the quantity of sex with the quality of sexual health. Survivorship medicine isn't about hitting a quota of 3 times a week. It is about feeling comfortable in your own skin again and maintaining a satisfying, secure connection with your partner.
So to understand why that comfort is so violently disrupted, we have to look at the mechanics of the treatments themselves. It's so important to understand the why behind the body's reaction.
It's vital for medical students and patients alike to grasp this.
Because once you see the biological mechanism, you stop viewing a lack of desire as a personal failure. It becomes a predictable, manageable side effect.
Exactly. It's physiology, not a relationship flaw.
Let's start with the surgical interventions.
Yeah.
The authors distinguish between a lumpectomy, which removes the tumor and a margin of tissue, and a mastectomy, which removes the entire breast.
From a macro perspective, the long-term studies show that overall sexual frequency doesn't differ wildly between those two procedures.
Okay, that's interesting.
However, the localized physical reality changes dramatically. The areola and the nipple are densely packed with nerve endings. For many women, this is a primary erotic zone.
Right.
When that tissue is surgically removed, those nerve pathways are physically severed.
Just cut entirely.
Yes. And even with incredible advancements in oncoplastic surgery, where the breast is reconstructed immediately during the tumor removal for cosmetic normalcy, the erotic sensation does not just bounce back.
Because the hardware is gone.
The wires are cut, essentially.
Yeah. Which means the survivor essentially has to remap their own nervous system. If a main highway is closed, you have to find the back roads.
That's exactly what it is.
The book talks about couples discovering entirely new erotic zones that were previously ignored. Like, heightened sensitivity can develop on the back of the neck, the inner creases of the arms, or even the collarbone.
The human nervous system is incredibly plastic, but remapping it requires immense patience and a willingness to explore without a guaranteed outcome.
Yeah, that takes a lot of mental energy.
It does. And surgery is just the first hurdle. If we look at radiation therapy, the exhaustion isn't just feeling, tired.
Right.
It is a crushing cellular fatigue that can last for a year. Plus, the skin on the chest wall can undergo severe changes. It becomes inflamed, thickened, and incredibly tender to the touch.
Which obviously makes physical closeness painful.
Extremely painful.
Though the authors do make a point to explicitly debunk a lingering, very isolating myth here. Receiving radiation does not make you radioactive to your partner.
Yes, I'm so glad they highlighted that.
Right. You are perfectly safe to sleep next to, touch, and be intimate with.
That reassurance is crucial for couples. But if we are looking for the treatment that causes the most systemic, catastrophic disruption to sexual functioning, it is undoubtedly chemotherapy and the subsequent hormonal medication.
It's systemic treatments.
Yes. To understand why, you have to look at the basic mechanism of how traditional chemotherapy functions. It is essentially a targeted poison designed to seek out and destroy rapidly dividing cells.
Because cancer cells are essentially like rogue cells dividing out of control, right?
Yeah, precisely. But chemotherapy isn't smart enough to only target cancer. It attacks any cell in the body that divides rapidly.
Oh, man.
And the epithelial cells that line the mucous membranes, which includes the vaginal wall, are some of the most rapidly dividing cells in the human body.
So they just get caught in the crossfire.
Exactly. The chemotherapy directly chemically burns and damages this delicate tissue.
And then you compound that with the hormonal therapies. Because many breast cancers are estrogen receptor positive, meaning estrogen acts like fertilizer for the tumor.
Yes, the cancer feeds on it.
So to stop the cancer from returning, doctors will prescribe aromatase inhibitors like tamoxifen, or they will surgically remove the ovaries.
Right.
By starving the cancer of estrogen, you are plunging the survivor into sudden chemical menopause overnight.
And we have to differentiate this from natural menopause, which is a gradual decline over years, giving the body time to adjust.
Right, a flow off-ramp.
But chemical menopause is like falling off a cliff. Without estrogen, the blood flow to the pelvic region drastically decreases. The vaginal tissue actually thins out, loses its elasticity, and becomes severely dry.
It's just a total shutdown.
It is. This creates a clinical condition called vaginal atrophy, and it leads directly to dyspareunia, which is the medical term for severe pain during intercourse. The biological environment literally becomes hostile to penetration.
Plus, there are the visible changes. We all know chemotherapy causes hair loss, but it's rarely discussed that it isn't just on the scalp.
No, it's everywhere.
You lose your eyelashes, your eyebrows, and your pubic hair. The authors point out a profound psychological consequence here, which said a completely smooth, hairless genital area can make a grown woman feel prepubescent.
It's deeply unsettling for many patients.
Now, I have to offer a bit of pushback here on behalf of the listener. I'm struggling with this a bit. If I'm exhausted from chemo, barely able to keep food down, and literally fighting for my life, the idea of mourning my pubic hair or my nipple sensitivity feels, I don't know, almost trivial. Am I missing something here?
It's a very common reaction to think it's trivial, but it entirely misses the psychological reality of human identity.
Okay, how so?
Well, these physical changes do not happen in a vacuum. A breast isn't just a gland. Hair isn't just dead protein. In our culture, and for many women personally, these things are deeply intertwined with their sense of womanhood, maternal identity, and sexual autonomy.
Ah, I see.
So losing them, especially while your actual sex drive is being chemically erased by estrogen blockers, is a devastating assault on your core identity. Mourning that loss isn't vanity at all.
It's grief.
Exactly. It is a necessary grieving process to protect your mental health.
That makes total sense. That concept is perfectly encapsulated in what the book calls sexual self-esteem, like how you view yourself as a desirable sexual being.
Right.
And reading through the case studies, you see how that self-esteem is just under heavy fire. But there are these incredible flashes of resilience. I absolutely loved the story of Magnolia Myrick.
Oh, her story's phenomenal.
She's a single woman in her 40s in the New York dating scene. She lost her hair, underwent a mastectomy, and she basically looked at the situation and said, absolutely not. I am not letting cancer steal my mojo.
She fully embraced the identity of a cancer vixen.
Yes. She bought high-end lingerie, threw on a wig, and actively forced herself to stay in the dating pool during treatment.
Her attitude was just so incredibly badass.
It really was. She figured that if a guy she brought home was put off by her surgical scars, he had a massive integrity issue anyway, and cancer was just acting as a highly efficient filter for bad dates.
Which is a brilliant way to reframe it.
But, that is the single experience. For women already in committed long-term partnerships, the dynamic shifts in a much more complicated way.
It really does. The partner often transitions practically overnight into a 100% full-time caregiver.
Yeah, that role reversal has to be incredibly tricky.
It is. Think about the daily reality for a moment. Your partner is tracking your nausea medications, helping you to the bathroom, cleaning up after you get sick. The dynamic fundamentally morphs from lovers to nurse and patient.
And during the acute phase of treatment, I imagine it is entirely natural and usually necessary to just de-emphasize sex.
Absolutely. The crisis comes 6 months to a year later when the acute treatment ends. The unspoken awkwardness of trying to cross that chasm back to being lovers, it can be paralyzing.
Imagine being that partner, right? You've spent a year terrified this person was going to die. You've watched them endure immense physical pain. So now you're lying in bed next to them, completely avoiding physical touch because you were just terrified of hurting them.
Yes, the fear is overwhelming.
But from the survivor's perspective, they just see their partner pulling away. So how do you distinguish between a partner who is secretly repulsed by your surgical scars and one who is just paralyzed by the fear of causing you pain?
Well, the short answer is you can't, not without explicit communication.
Really, just pure guesswork otherwise.
Exactly. Silence in that scenario is a breeding ground for toxic assumptions. The survivor internalizes the hesitation as physical rejection, which further damages their sexual self-esteem.
And the partner internalizes their own hesitation as protective love.
Precisely. The authors emphasize that you have to explicitly vocalize these fears. You have to say out loud, I miss you, but I am scared to touch your chest because I don't know what hurts.
Just putting it all out there. The book also dives into the specific dynamics of same-sex couples, which I thought was really insightful.
Yes, lesbian couples often share a deep, empathetic understanding of what breast changes mean, both culturally and physically.
But they face very specific hurdles too, right?
They do. In many lesbian relationships, breast stimulation is a highly prioritized primary erotic zone.
So if that tissue is removed or desensitized, It leaves a massive structural gap in the couple's sexual routine.
Exactly. Additionally, many survivors are prescribed certain antidepressants to help manage the severe hot flashes of chemical menopause. These medications, specifically SSRIs, are notorious for severely blunting clitoral arousal and delaying orgasm.
Oh, wow. So you lose multiple pathways.
Yes. The loss of these specific physical pathways can lead to what sociologist Pepper Schwartz calls lesbian bed death, which is a profound drop in sexual passion.
Let's talk about that drop in passion, actually, because the text makes a vital distinction between lust and love. Couples often panic when that fiery, spontaneous lust disappears during cancer treatment.
They mistake the loss of libido for falling out of love.
Right, but it's so important to look at the neurochemistry here. That initial obsessive, spontaneous lust you feel at the beginning of a relationship, there's a highly specific chemical state in the brain.
Yes. Evolutionary biologists and neurologists note that this intense, passionate phase rarely lasts beyond 18 to 24 months in any relationship.
In any relationship, cancer or no
Not
cancer.
exactly. It naturally transitions into deep, intimate attachment love. Now, cancer treatment will absolutely extinguish whatever spontaneous lust is left, mostly by suppressing testosterone and estrogen.
Right, it speeds up the process.
But the absence of lust does not mean the absence of love, and it doesn't mean physical intimacy is gone forever. It just means you have to switch from passive, spontaneous desire to active, cultivated desire.
So how do we actively cultivate it? Because this is where the book shifts into highly actionable territory, right?
Yeah.
Reclaiming the body.
Yes, moving from theory to practice.
Since a lack of estrogen physically shrinks and dries out the vaginal tissue, we can't just rely on changing our mindset or communicating better. We have to physically and mechanically rehabilitate the area.
We do.
Let's start with the most common issue: severe dryness and friction.
The absolute first step is understanding the clinical difference between a moisturizer and a lubricant.
Okay.
Vaginal moisturizers are used regularly, usually every few days, similar to how you would use a daily face lotion. They are designed to absorb into the tissue, alter the pH, and maintain hydration over time.
Got it. And lubricants.
Lubricants, on the other hand, are strictly for the time of sexual activity to immediately reduce friction.
But you can't just grab anything off the drugstore shelf, right? The tissue is
Yeah.
incredibly compromised.
Formulation is everything here. The authors explicitly warn against using products containing glycerin or parabens.
Why is glycerin bad?
Well, glycerin is a sugar derivative. Introducing it to a vaginal environment whose pH is already thrown off by chemical menopause is a fast track to severe yeast infections and burning.
Oh, yikes.
Yeah, you want to avoid that. They recommend medical-grade, organic water-based, or silicone-based options, noting brands like Good Clean Love as safe benchmarks.
Okay, so moisturizers and good lube. But lube doesn't solve everything. If radiation or atrophy has caused the vaginal canal to actually shorten or lose its stretch, the authors introduce a concept that sounds, honestly, a bit intimidating.
You're talking about vaginal dilators and pelvic floor physical therapy.
Yeah, it sounds clinical and scary.
Yeah.
But reading it, I realized it's exactly like physical therapy for a joint that's been in a cast.
Yes, that is a brilliant way to explain it.
Like, if you break your leg and it sits immobilized in a cast for 6 months, the muscles atrophy and the tendons shrink. When the cast comes off, you can't just immediately sprint a 5K.
No, the tissue would tear.
Right.
Yeah.
You have to undergo weeks of gentle, graduated stretching to regain the mechanical elasticity of that limb, not just look for a quick fix. So a dilator is basically physical therapy for the pelvic floor.
Exactly. Vaginal dilators are smooth, graduated cylinders. Using generous lubrication, a survivor will use them often for just 10 or 15 minutes a day.
Just a little stretching.
Right. The clinical goal is to gently, mechanically stretch out the radiation-induced scar tissue and re-educate the vaginal walls to expand without tearing.
Wow.
This is often paired with pelvic floor physical therapy, because when a woman anticipates pain during intercourse, the pelvic muscles will involuntarily spasm and clamp shut a defense mechanism called vaginismus.
Oh, so the body's trying to protect itself.
Exactly. A specialized physical therapist will work to break that pain spasm cycle, sometimes even utilizing localized muscle relaxants.
Moving beyond physical therapy, the medical devices and pharmacological options available are fascinating. Because again, we are dealing with a biological deficit of blood flow here. The book details the Eros clitoral therapy device.
Yes, it is an FDA-approved, prescription-only device. It's essentially a small, handheld vacuum that fits precisely over the clitoris. Yes, because the body lacks the hormones to naturally trigger vasocongestion, which is the swelling of erectile tissue with blood during arousal, this device physically forces the issue.
Oh, I see.
It uses gentle suction to draw blood flow into the nerves, artificially creating the physical state of arousal that the brain and hormones are failing to produce.
That's incredible. And what about hormones? We established earlier that estrogen acts like fuel for many of these tumors, so oncologists block it. Is it ever safe to introduce estrogen back into the body to heal the vaginal tissue?
This is a highly individualized conversation for patient to have with their oncologist, but the blanket ban on estrogen is lifting for many survivors.
Really? Why is that?
The key is systemic versus localized absorption. Swallowing an estrogen pill floods your entire bloodstream, which is dangerous for a breast cancer survivor.
Right, feeding the tumor.
But localized estrogen, like a Vagifem tablet or an S-string ring inserted directly into the vagina, delivers a microdose of the hormone strictly to the local tissue.
So it stays right there.
Exactly. It restores the pH, the elasticity, and the moisture, with studies showing very little, if any, absorption into the broader systemic bloodstream.
That's a game changer. The authors also highlight some really interesting non-hormonal avenues for women who can't take any estrogen at all. They discuss a drug called flibanserin and topical botanicals like Zestra arousal oils.
Right. Flibanserin is fascinating because it targets the brain, not the genitals. It alters the neurotransmitters in the prefrontal cortex.
So it's working on the software, not the hardware.
Precisely. It essentially lowers serotonin, which can act as a brake on sexual desire.
And it boosts the accelerator.
Yeah, it boosts dopamine and norepinephrine, which act as the accelerator. Zestra, on the other hand, is a clinically studied botanical oil.
How does that one work?
Well, since the hormonal pathway to arousal is blocked, Zestra utilizes plant extracts to trigger the TRPA1 ion channels in the nerve endings.
Okay, getting scientific here.
Yes. It creates a localized, warming, tingling sensation that completely bypasses the hormonal deficit and directly stimulates the nerves to mimic arousal.
So we have moisturizers for daily health, silicone lubricants for friction, dilators for mechanical elasticity, vacuum devices for blood flow, and neurotargeted drugs or botanicals for sensitivity.
It is a massive toolkit.
It really is, a toolkit to rehabilitate the hardware of the body. But how do you fix the software? I mean, if you are exhausted, traumatized, and stressed, how do you reignite the mental spark of connection?
That is the ultimate challenge, because the brain is the largest sexual organ.
Very true.
The book heavily references the incredible research of Dr. Lori Brotto on mindfulness and sexual health. When we are dealing with chronic illness, we slip into a default mode network of mindlessness.
Just going through the motions.
Exactly. We live on autopilot just to cope with the medical appointments and the low-level chronic pain.
Yeah, your brain is constantly generating anxiety about cancer recurrence or, I don't know, just the grocery list pulling you out of your body.
Right. Dr. Brotto's mindfulness training is about deliberately anchoring your awareness in the present moment sensory details.
How does that look in practice?
During intimacy, instead of letting your mind catastrophize or judge your body's performance, you actively force your brain to focus on the exact texture of the sheets against your skin. You focus on the ambient temperature of the room, the specific rhythm of your breathing, the smell of your partner.
Oh, wow.
By flooding your brain with immediate sensory data, you ground your nervous system. It actually shuts down the anxiety centers of the brain and significantly reduces the perception of pain.
It's about getting out of your own head and back into the room.
Exactly.
The sources also dive deep into the actual chemistry of connection, beyond just sexual arousal. They highlight research by Dr. Helen Fisher and Dr. Arthur Aaron regarding the sheer power of novelty in long-term relationships.
That research is fantastic. They found that engaging in novel, challenging experiences together actually floods the brain's reward system with dopamine and norepinephrine.
The accelerator again.
Yes, it literally replicates the exact neurochemical state you were in when you first fell in love.
And for moments when penetrative sex is just entirely off the table, the authors heavily emphasize the release of oxytocin, which is often called the cuddle hormone.
Right. Simple, non-sexual, touch-like, holding hands, hugging for more than 20 seconds, or spooning in bed triggers a massive release of oxytocin.
And what does that do chemically?
It actively suppresses cortisol, the stress hormone, and builds deep neurological feelings of safety and attachment.
Which is why the book warns so strongly against falling into the RUT, right? The routine, unimaginative, and tiresome evenings.
Yes, the RUT is dangerous.
Because when sex becomes difficult, couples often retreat to separate corners of the couch, watch the same TV shows, and go to sleep without touching. The authors suggest TV-free date nights, reading erotica together, or taking a weekend trip away from the cancer environment of the house.
All great suggestions.
Now, I have to jump in here with another reality check. Because if I am listening to this, and I am currently recovering from the bone-deep fatigue of chemotherapy, the idea of having to plan novel and challenging dates sounds completely exhausting. I mean, I barely have the energy to make dinner, let alone curate a thrilling romantic adventure.
That is a very valid reality check. But we have to rescale our definition of novelty.
Okay, rescale how?
Novelty in this context does not mean booking a trip to Paris or going rock climbing. It simply means breaking the neuro autopilot. It's about introducing a small, new stimulus to wake up the relationship's dynamic.
Oh, so it can be really low-key.
Extremely low energy, like ordering takeout from a restaurant you've never tried, or playing a new two-person card game on the living room floor instead of eating at the table.
Just breaking the routine.
Right, even just reading a chapter of an audiobook together to spark a conversation that isn't about doctor's appointments, it's just about breaking the script.
Small pivots to remind yourselves that you are partners, not just co-managers of a medical crisis.
Beautifully said.
Let's take a step back and look at the massive journey we've covered today. We started by validating the brutal biological realities of oncology, how surgeries sever nerve pathways, and how chemical menopause physically alters the body's elasticity and blood flow.
We confronted the heavy psychosocial toll, too. The loss of identity, the shifting caregiving dynamics, and that terrible silence in the doctor's office.
But we didn't stop at the trauma. We mapped out the highly specific mechanical and chemical tools available to rehabilitate the body.
Right, the dilators, the localized estrogen, the neuro-targeted medications.
And we explored how to actively rewire the brain's approach to intimacy through mindfulness, targeted sensory focus, and low-energy novelty.
Before we wrap up completely, I want to leave the medical students and clinicians listening with a quick review exercise to reinforce what we covered.
Oh, I love this. Test our knowledge.
Think about the physiological difference between natural menopause and the chemical menopause induced by aromatase inhibitors. How does that rapid estrogen deprivation directly alter the epithelial cells of the vaginal wall? And biologically, why does that make glycerin-based lubricants absolutely contraindicated?
Oh, that is a great question to chew on, tying the biology directly to the clinical recommendation.
Wow, exactly. It's crucial to understand the why behind the treatments.
Absolutely. It makes you wonder, imagine if tomorrow you woke up and your physical abilities had radically changed overnight. Your go-to methods for feeling close to your partner were suddenly painful or impossible.
It would be terrifying.
It would. How would you find intimacy without the automatic physical routines you rely on? It forces you to completely separate the mechanical act of sex from the emotional state of intimacy.
And that separation leads to a profound realization. Navigating a crisis like breast cancer forces a couple to communicate about vulnerability, physical boundaries, and deep-seated fears in ways they likely never would have in a perfectly healthy life.
It strips everything back.
The shared trauma strips away all the superficial layers of the relationship.
Which means that instead of cancer being the definitive end of your sex life, surviving it could actually serve as the catalyst for a completely new era of intimacy.
Wow, yes.
You are no longer relying on the easy, automatic lust of your early years. You are actively, consciously building a mature, resilient connection that has survived the absolute worst.
You've survived the shipwreck, you are on the new shore.
The new shore, I love that.
The old maps of your body and your relationship might not work anymore, but with the right tools and the willingness to communicate without shame, the life you build on that new terrain can be deeper and richer than anything you had before the storm.